Well, welcome everyone. My name is Chad Cook. I'm a professor at Duke University in the United States, and I'm very honored to be asked to talk a little bit about differential diagnosis in musculoskeletal disorders. Again, my background is a tenured professor in the Department of Orthopedics at Duke University. I'm also a member of the Duke Clinical Research Institute, and I have a secondary appointment in the Department of Population Health. I have a 30-year background as a physical therapist. I have published approximately 3 books, 2 in their second edition, 1 moving into its third edition. Former editor-in-chief of the Journal of Manual and Manipulative Therapy, currently a special topics editor at JOSPT, and a senior associate editor at the British Journal of Sports Medicine. I am a fellow in manual therapy with AONT from the United States, and I am a Catherine Worthingham Fellow with the APTA. I'll post my disclosures. Again, I'm not receiving anything financially from this presentation. I do so because I'm happy to do it, but I do have some financial connections with selected groups around the world. I have a few very important objectives that I'd like to cover today. The first is I want to overview how we're doing presently in the management of musculoskeletal disorders. We'll talk a little bit about how diagnoses are created, since this is the primary topic that we're considering. We'll talk about what's unique about a musculoskeletal diagnosis that's maybe different than cardiac or neuro or other conditions. And then we'll talk about how physios around the world use clinical tests in their differential diagnosis and how well that works within the framework of a musculoskeletal diagnosis. Lastly, we'll talk about how sometimes the differential diagnostic process actually works against us when we're managing musculoskeletal disorders, and then I'll finish this off with a few recommendations. But first, let's talk on an overview of outcomes associated with musculoskeletal medicine. Well, we know this, that despite our younger millennial population theoretically being more health conscious and being the developers of a lot of new initiatives, such as the use of yoga and other lifestyle characteristics, 8 of the top 10 millennial-based health conditions include depression, substance use disorder, high blood pressure, hyperactivity, Crohn's disease, and ulcerative colitis, high cholesterol and tobacco use, as well as type 2 diabetes. And these are actually very characteristic of Gen Xers, of older individuals, of the chronic comorbid conditions that we deal with around the world. In fact, these are actually more common than their forebears. So despite us thinking that they're more healthy, in reality, our younger population is less healthy than our current older population. In fact, what we're seeing, what is remarkable, is a major decline in health starting about the age of 27. That's pretty remarkable. Our magic number used to be 50, and then it dropped to 40, and now we know that physiologically we start to see changes, mentally we start to see changes at the age of 27. In fact, certainly in my country, the United States, we have seen an increase in substance abuse disorders and dependency, and a remarkable increase in the number of behavioral health and mental health related visits for management of that particular problem. So why is this? Why are we starting to see declining outcomes? Well, I can argue that within the area of pain management and musculoskeletal health, it's because we still, as a whole, don't follow our clinical practice guidelines. And our clinical practice guidelines, although they're a summary of the best evidence, do give us a roadmap of management processes. But that's not the only thing that's the problem. There is a compelling argument that we really don't use the treatment approaches that theoretically can influence patient outcomes the most. And we'll talk about that in more detail. In other words, we're doing things with patients that probably don't influence their overall health-related outcomes. It boils down to this. If we look at our long-term trajectory with respect to outcomes, and we perform a trends analysis, that despite the millions in research funding development of multiple guidelines. In fact, there are 39 guidelines for low back pain, numerous classification systems, and hundreds of thousands of musculoskeletal articles, our outcomes are actually worsening. They are worsening over time, especially low back pain, which is the #1 cause of disability. So our takeaway from this, we're not doing well and we need to do better. So let's talk about one theoretical way that we can actually improve our outcomes. Maybe it's related to diagnosis. Let's talk about first how diagnoses are actually created. Diagnosis comes from the Greek word of dia and gignoskin, which means to judge or to think. So think apart, or know apart, or discern, or distinguish. These are all words that are related to the idea of diagnosis. Differential diagnosis is a systematic process. And it's important to know that it's a systematic, ongoing process that doesn't just stop on that first visit. It's something that continues as you manage that patient. In fact, there are many instances in which diagnoses will change as you acquire more information from that patient. But in its true reflection, diagnosis is the ability to distinguish a condition from other competing possible diagnoses, other masquerading conditions. That is what a diagnosis is. Why should we have a diagnosis? Why is it necessary? Well, it allows us to build classification tools. It improves our ability to communicate across all health-related disciplines. It provides a trajectory. In other words, if you have a strong diagnosis, you typically also understand the prognosis. And in some cases, if you understand the diagnosis, you can do preventative measures. But I will talk about how that is potentially risky and often overdone. Probably the biggest reason that we want to have a diagnosis is because we are interested in avoiding medical errors. In other words, mismanagement of patients, misdiagnoses, and potentially mortality. In fact, in my country, medical error is the third leading cause of death behind heart disease and cancer. And I find that just absolutely remarkable. And the #1 reason for medical error is a misdiagnosis. We know that diagnoses have been around for a very long time. In fact, it was the French that first suggested a diagnostic classification. And this really built the foundation of our current ICD classification models. The ICD-10 and now ICD-11 systems are formal criteria that have been developed so that we have consistent diagnoses across all potential frameworks. The fact is, there are over 55,000 different diagnoses within the ICD-11 classification. These are all governed by the World Health Organization. And the World Health Organization is a specialized agency of the United Nations that is funded by different countries. It was established in 1948 in Geneva, Switzerland, and they're especially in the news this day and age with our viral outbreak and the suggestions that they make around the world to improve the health of all countries. There are essentially 2 types of diagnoses that are built within the ICD-11 diagnostic framework. There are biomedical signs, and these are the most common, signs being the anatomical elements that are typically seen in patients. And then there are syndromes, which are not related to an anatomical malady. These are the least of the common types between the two, but syndromes have increased in number recently. But traditionally, ICD-11, ICD-10, ICD-9, and all the classification systems before that were primarily biomedically based. Let's just look at signs versus symptoms again. A sign is more biomedical. It's a phenomenon that can be detected by someone else. So it's a tear or a fracture or a tumor or something that is palpable, manageable, and seeable. A symptom or a syndrome is related to something the patient says. So it's very subjective tends to be different from patient to patient. You often see overlapping of symptoms, and it's much more challenging to wrap our arms around. In order to create a new diagnosis, and by the way, they create new ones every year at different paces. And some years it may be 40 new diagnoses, some years it may be 5. You have to qualify with 4 different criteria within the World Health Organization. It must have definitive signs and symptoms. It must have definitive diagnostic guidelines, differential diagnoses, and populations at risk. And the overlap between a particular suggested diagnosis and one that already exists mustn't be so much that it can't be its own unique diagnosis. And it's a real challenge because nowadays what we're seeing is a massive proliferation of diagnoses. In fact, I love this quote in this wonderful paper by Bjorn Hoffman. He says, "Disease is expanded by making more things count as disease." In other words, behaviors, feelings, emotions, and sensations. And this, by the way, is called medicalizing. And we'll talk about that at the end of the lecture because it's really, really important to understand how this can actually lead to both positive and negative consequences. We actually tried to validate a disease recently and published the work in the Journal of Science and Medicine and Sport. It was on a concept that is very US-centric or North American-centric called second impact syndrome. And the idea behind second impact syndrome is that if someone has a concussion and then has a subsequent concussion, it can lead to all types of brain-related changes, including a brain bleed. But when we evaluated the criteria in registered cases of individuals with, quote, second impact syndrome, we realized that it didn't actually meet the guidelines, the 4-step guidelines of the World Health Organization. So it has to go through a lot of rigor before something is actually considered a diagnosis. Let's move to our next section, and let's talk about what's unique about a musculoskeletal diagnosis. Well, it's unique in that you're dealing with signs and symptoms, and there are most likely 4 distinct classifications within a musculoskeletal diagnosis for each body part region. So an easy one to consider is low back pain. Low back pain is very prevalent. It's something that all of us see. And within a diagnosis of low back pain, there may be 4 potential classifications of types of diagnoses. There may be a biological red flag. There may be a distinct region-specific disorder, and I'll define what I mean by this in a second. There may be somatization, which is a non-specific component that you can't distinctly link to a biological process. And the third is a recalcitrant, ongoing chronic pain condition, also not related to a distinct biological process, nor is it any longer related to a biological trigger or a peripheral trigger. This is incredibly important. And in fact, I put a triangle with an exclamation mark on each slide that I think is a takeaway slide, a slide that is of utmost importance. If you recognize that there are 4 potential classifications of a diagnosis within a body part region, it helps us understand why we see such a great variability in the diagnostic accuracy of our clinical tests, and why individuals with the same diagnosis will often have a completely different presentation. Again, let's look at these 4 distinctly because it's worth addressing. What is a red flag? Well, it's typically a sign, but it could be a symptom that's found in a patient history or clinical examination that ties a condition to a serious pathology. If we know that it could lead to a really negative outcome, sometimes that's called a prognostic red flag. But a diagnostic red flag is typically a sign or a symptom that is related to a serious problem. These are unequivocally rare. You don't commonly see these. In many cases, it's less than 1% in most body part regions. It's a situation, though, that when you find a particular problem, you need to know how to act upon that accordingly. And that's why I really like this recent paper by Laura Finicum, in which they actually give you a process to follow if you see a potential red flag. And if you follow their flow, if there are no concerning features, then there would be a very low level of concern and you don't need to act. If there are a few, then you can still manage that patient within a trial, use monitoring or watchful waiting or something of that nature. But if there are high levels of concerns, then it requires an urgent referral, maybe to an urgent care center, or an emergent referral to an emergency department or an emergency care environment. In both of those situations, you should not initiate with care of that patient. You should have other elements ruled out first. Again, not very common, very challenging to actually identify these because, as many authors have indicated, the clinical tests just aren't very good. We've published on this before in BJSM and others, according to Finicum, has indicated this. Ari Downey has pointed this out as well. The clinical tests just aren't very good. The second piece is a distinct region-specific disorder. And what we mean by this is we can tie that particular problem to an anatomical origin. In other words, we know what's going on with that condition. It's not a red flag, it's not a fracture, it's not a tumor, it's not something of that nature, but it is related to an anatomical problem. And in general, most clinical tests will help identify this fairly easily. Classic examples would be lumbar radiculopathy. We know that's related to some sort of mechanical tension or compression on the nerve root that has a chemical stimulus. An ACL tear, very manageable, very easy to see, very definable. An ankle sprain, lateral epicondylosis, a disc herniation. DJD and DDD have distinct biomarkers and have a distinct representation on imaging. Despite what people say, despite what social media suggests, these actually are fairly clearly defined in the literature by biological markers. And then lumbar stenosis with neurogenic claudication, very definable, very clear. These are great examples of specific disorders. And if you look at the clinical tests and measures in the majority of these conditions, they do function fairly well. Most of the ACL clinical tests are very good tests, and the reason is because it's a distinct region-specific disorder. Somatization is when an individual will come seeking care, but they have no pathophysiological explanation to point to as a reason for the symptoms that they're actually receiving. It typically occurs in non-specific conditions, and there are many types, and it's likely related to the phenotyping and the individual's ability to self-modulate their pain. That's variable across the board. Some individuals will actually experience their pain experience is more traumatic than others, and in those cases, they will have somatization of pain. Classic examples of somatization of pain disorders are non-specific low back pain, rotator cuff related disorders. These would be your low Snyder level SLAP lesions, impingement syndrome, a small rotator cuff tear, rotator cuff tendonitis. They all have very overlapping symptoms. They feel very similar, and it's very difficult to differentiate those conditions. Lateral hip pain, interarticular hip pain, and anterior knee pain all could be a variety of different diagnoses, but there's such a heavy overlap in the symptoms that it's very difficult to differentiate these conditions. In most cases, our clinical tests don't do very well when dealing with individuals who have somatization. So that's one of the reasons why the values of a lot of tests, especially for non-specific low back pain or rotator cuff testing, they're just not very good. The last of the four conditions is recalcitrant ongoing chronic pain condition. And in many cases, some individuals will call this a chronic pain syndrome. And this is where the person has had pain for so long and it's been part of their life so much that it's changed their functional mechanism of how they actually experience pain. So there's been a change in their central nervous system according to that pain. And they're no longer are required to have a peripheral trigger to actually have that painful experience. Now, this is not that common, but it's extremely difficult to treat. And there are many examples of this in the literature, case reports, or in individuals on social media that talk about someone they work with who had chronic pain syndrome. Keep in mind, this is not the majority of your population. It's extremely difficult to treat, and they do require a different form of management. Also, your clinical tests are not going to identify this particular patient population. It's very challenging to identify. How challenging is it? Again, we have our triangle with the explanation point. This is a takeaway slide. This is one of the things you need to consider when that patient is standing in front of you and you're considering trying to diagnose a condition. We know that red flags are extremely important to diagnose, but our clinical tests just aren't very good. In fact, if you look at the systematic review, meta-analyses of those clinical tests, they are not able to distill out a person that has a red flag. In many cases, we have to use our own intuition. Thank goodness they're rare, so that our chance of missing these are reduced, but nonetheless, they're very difficult to diagnose as the clinical tests aren't very good. Region-specific disorders like an ACL tear or lumbar radiculopathy or something like that, most of the clinical tests are actually pretty good for these conditions. And that's because we can typically tie those conditions to a definitive biological process. That's different with somatization. In those particular situations, it's very difficult to make a clinical diagnosis because we have overlapping symptoms. We don't necessarily have a biological or tissue-based reason why that person has the condition. And our last group is recalcitrant pain. If you try to use a clinical test for this, you'll have no success. Instead, we need to consider using scales or other devices or tools that are more pen and paper related, like an OSPRO or a start back or an Orabro or something of that nature to give us a better perspective if the person is dealing with a problem that is more chronic pain syndrome oriented than it is biologically oriented. Let's move on to our next level. And let's talk a little bit about how physios use clinical tests in their differential diagnosis. Because most likely, a majority of the listeners may have thought that the only way to make a diagnosis is through clinical testing. Well, we know it's an evolving process. Historically, we have used clinical tests. That was our only avenue to get to that clinical diagnosis. We know that with the advent of diagnostic ultrasound, it's opened our opportunities to actually make a imaging-based diagnosis. And recently, we've started using something called a pain and disability drivers, recognizing that not all diagnoses are nociceptive-based. A classic example would be chronic pain syndrome. Not yet completely, but prognostic modeling has been developed, and we're going to talk more about that near the end of this presentation. Clinical testing. Well, if you're like me, you probably studied using classic tests such as Stanley Hoppenfeld's Spine and Extremities Physical Examination Textbook. It was created in 1976 and it has never been changed. And it has these wonderful illustrations. And it talks about if you use specific clinical tests, then the likelihood of making that diagnosis during your clinical examination is going to be fairly good. What's interesting is Hoppenfeld actually modified many of the tests that he demonstrated in his presentation in his textbooks to match what he did in the clinic. And he actually changed a lot of the clinical tests from their historic use. In fact, there is a bottleneck of changing clinical testing that is primarily responsible from Hoppenfeld, because Hoppenfeld would sell anywhere from 20 to 50,000 textbooks a year. In reality, we know now that diagnoses are more sophisticated than some of the simple tests used and represented in Hoppenfeld's book, and that clinical testing is useful in some cases, but certainly not all. Again, diagnostic ultrasound has been something that is under the purview of many physical therapists in many different countries, but it isn't available in a lot of different countries. So the use of diagnostic ultrasound, although it appears to be about as accurate as an MRI, is not used by a majority of physical therapists. It could be useful in differentiating anatomical conditions, but it's not used as frequently as we thought. The pain and disability drivers model is something that was created by Yannick Tousignan-Laflamme and me. And what we decided was, instead of trying to square peg in a round hole a diagnosis to try to determine the cause of pain and disability, let's look at the primary drivers and then determine the best tests that fall and fit within those drivers. So we know there are nociceptive pain drivers. And in a majority of musculoskeletal conditions, most diagnoses are built around this, nociceptive pain drivers. In other words, what are the primary reasons that are causing the pain of the individual? Another area, which is a driver of pain, are nervous system dysfunctions, or the hypersensitive nervous system. These are nerve-related drivers or neuropathic drivers. This might be myelopathy or radiculopathy or central sensitization. We know that these are conditions that are frequently seen as well. In fact, these are your primary drivers for individuals who have chronic pain syndrome. So there are tests and measures, both clinical and tool related, that can capture for nervous system, and there are a multitude of clinical tests and measures that are primarily created for nociceptive pain drivers. The third category are comorbidity drivers. And comorbidity drivers are essentially things such as sleep disorders, concomitant musculoskeletal problems such as OA or diabetes or other conditions that can actually amplify a typical musculoskeletal problem. There are some clinical tools that are used to actually diagnose this, but not all are available for physical therapists. In many cases, you also have to use health status measures or other tools that go beyond our traditional clinical examination. Cognitive emotional drivers are those related to a person's thoughts and emotions. And we know that these can mediate a lot of the outcomes associated with nociception or the nervous system. And there are many pen and paper tests that are used to define these conditions, things such as expectations, negative cognitions, illness perception, self-efficacy, coping, pain avoidance behaviors. All of these are elements that fit within cognitive and emotional. The last section are more drivers of disability only, and these are environmental or social drivers. So social environmental drivers, sometimes called social determinants of health, are huge and can markedly influence outcomes. And these are commonly forgotten during our clinical examination process. And it's probably best to use pen and paper tests to define these disorders as well. Certainly your traditional clinical tests that you'll learn in a textbook are not going to be useful in this, but they're so important because we know they influence outcomes dramatically. So we've talked a good bit about where diagnoses come from. I mentioned earlier that we have declining outcomes over time. I mentioned that most clinicians use special tests or clinical tests during their diagnostic process, but we have to be cognizant that there are really 4 different types of diagnosis in a given region. There might be a red flag, there is a specific problem, which is what we typically learn in school. There are non-specific problems, which is called somatization. And then there are chronic pain syndromes, which they no longer even need a peripheral nociceptive trigger to have a pain experience with that patient. If that's the case, if we have this jumble of things, does a diagnosis even matter? Well, I would argue that it does, but within limitations. And again, a very important slide, something to take away. In many cases, because we deal with these unknowns, non-specific disorders such as somatization and chronic pain syndromes, in an effort to define what's going on with that patient, there are many cases in which we create something out of nothing. And medicalization is the process of diagnosing something as a pathology, which is a normal social, behavioral, or bodily condition. In other words, we give it a label, we think it needs a treatment, and we pathologize it. And this is especially common recently by the pharmaceutical industry. It's especially common in North America with the growth of diagnoses that are driven by the medical industry. And it's especially common by consumers who are driving to things to fix anything that they consider abnormal. So we have medicalized birth, we have medicalized death, and we've medicalized all things in between. On the physical therapy side, this can lead to a number of false diagnoses. Now, if you're interested in this, I would recommend you read a recent paper that we wrote. It was Jeremy Lutz, Peter O'Sullivan, Tammy Hoffman, and me, and it's called Too Much Medicine, the Elephant in the Room. And we published it with JOSPT. And we talk about many of the frameworks that can lead to too much medicine or medicalization. And then I want to give you a few examples here that can lead to these false diagnoses that are not recognized by the World Health Organization. So similar to second impact syndrome, they created a life of their own based on some clinicians' thoughts, but in reality, they don't meet the criteria for a diagnosis, and we may be pathologizing normal findings. So the classic example, probably the most pathologized condition, is sacroiliac joint dysfunction. And this is the assumption that the pelvis is out of whack, that it's out of alignment. You'll hear the terms upslip, inflare, outflare, downslip. These are all made-up terms that have not been shown to exist. This is a way of pathologizing normal lumbopelvic disorder that's non-specific in nature. Scapular dyskinesia is another case of a false diagnosis, not recognized by the WHO, and we create something out of nothing based on a malposition of the scapula. Altered craniosacral rhythm, T4 syndrome. Piriformis syndrome is not specifically recognized by the WHO. There are several conditions that may be of overlap, but not specifically piriformis syndrome. Adverse neurodynamics, and first rib dysfunction. By telling patients that they have these conditions, it creates this expectation that there's something wrong with them, that they have a pathology, when in reality these may be normal somatization experiences that can be easily managed through appropriate discussion with the patient and a more cautious approach. The most common medicalized normal process are mood disorders. People naturally get anxious or sad or concerned with day-to-day processes through their life. But what has happened is we have now pathologized these behaviors or moods or cognitions, and we've turned them into conditions or diseases. And what has happened is you've seen a massive increase in the amount of medication that's provided. In my country, which is traditionally overweight, individuals on antidepressant drugs than we do on hypertension drugs. That's remarkable. But what this has done now has flowed over into the physical therapy framework, and we are now diagnosing individuals with a number of different types of mood disorders and managing them through cognitive behavioral therapy, when in reality, their problem might specifically only be related to pain or their dysfunction. And if appropriately managed, the pain and dysfunction, then in many cases, these concomitant psychological processes will go away. So the biggest danger we are in now is this amplification of pathologizing normal moods that are related to musculoskeletal problems. So the real question, do we really need to know diagnoses for musculoskeletal pain? Again, if we address our 4 different possible types of classification of diagnoses within a body part region, yeah, we definitely need to recognize red flags. We don't want to miss those. They're not very common, but we do need to make a diagnosis for that. And indeed, specific disorders we can better manage those conditions if we have an appropriate diagnosis. If they have an ACL tear, then in theory, I should be able to manage that better than if I did not know they had an ACL tear. But somatization and recalcitrant pain, it probably isn't going to matter. The juice is not going to be worth the squeeze if I go in and try to identify the tissue related to those particular conditions. Instead, I probably don't need a diagnosis to manage those. And in some cases, if we try too hard, it can lead to detrimental problems. In fact, there are 11 trials for low back pain and knee complaints that suggest that routine diagnostic imaging, this fervent effort to identify the tissue related to the problem, is not beneficial, and it can actually make symptoms worse in the patient and affect their outcomes more substantially. There is a condition called overdiagnosis. And overdiagnosis is where you take a musculoskeletal problem that has a positive prognosis and you overmanage it. You make it a mountain out of a molehill. You make it worse than what it actually is. And that subsequent treatment may actually do more harm than it will good. We see this in a number of screening processes. We see this when we screen for postural problems, or when chiropractors look for subluxations, or some of these fake things that aren't really problems. It can actually increase the amount of treatment and cause harm in those patients. It's really important that we understand prognosis as much as we understand diagnosis. And in many cases, we don't. I have seen this literature before. In medical school, 95% of the effort goes toward diagnosis and only 5% goes toward prognosis. Why is this important? If you understand the prognosis of a particular condition, and you know that it has a favorable natural history, then how you manage that patient is going to be quite differently, regardless of what their clinical diagnosis is. The prognosis will affect management. So why focus on this? Well, it affects management. It helps identify a group of patients who are either high risk or at low risk for poor outcomes, and it reduces overtreatment. Probably the best thing about prognosis is it really reduces the amount of care that's provided to the patient. That's if you understand prognosis. Now, if you've ever sat back and thought about prognosis, you probably recognize that you don't know a lot of the prognostic trajectories of a number of different conditions. You can probably define some prognostic factors that are risk factors for a poor recovery. But do you know the prognosis of early spinal cord myelopathy? How about the prognosis of chronic low back pain? What is the prognosis of whiplash-associated disorder, and what mediates that prognosis? What's the prognosis of degenerative meniscus injuries? And what's the prognosis of a hamstring strain? If you understand the prognosis and the subtypes within those prognoses, you can more effectively manage your patient. So I want to make a few recommendations before I sign off with respect to diagnosis. And for many of you taking this and maybe enjoying the presentations that were offered by our colleagues, you probably are wondering, why didn't I talk about tests and measures? Well, this is a much higher order, higher level of thought with respect to diagnosis. If we understand the framework around diagnosis, then we can better fit the really insignificant areas like clinical testing within that framework. And if you understand that, you're going to be a better clinician. So with respect to that, let's look at a few recommendations. Again, we need to shift the way that we think and the way that we train and the way that we consider when we manage patients. We need to shift from a diagnostic framework to a prognostic framework. And it's incredibly imbalanced in our training right now. And you probably recognized from my earlier queries, you may not know the prognostic expectations of many of the typical conditions that you treat. We need to know that. We need to not be part of the problem, but be part of the solution. And one way to get around being part of the problem is let's step away from making the mistakes that our forebears may have by pathologizing conditions that maybe have a favorable prognosis or just may need to be managed by normal strengthening and mobility. We don't need to label everything that we treat. Perhaps a somatized condition is non-specific low back pain, and it is expected that up to 65 to 80% of the diagnoses that we see are somatized conditions. So the majority of the patients that we see are going to fall into this classification of diagnostic type. We need to learn to live with it and not make it worse for the patient. We also need to know that sociologically, that things are going to change, that diagnoses are going to change over time, and we need to be flexible. We need to be nimble and adaptive, and we need to recognize that there will be some diagnoses that in the future will not be diagnoses. Something like shoulder impingement syndrome, which is essentially withering up and dying as a diagnosis because it does not have the appropriate diagnostic framework to be an independent diagnosis. But what's remarkable, these were former diagnoses. These were recognized by the medical community as diagnoses. Witchcraft, homosexuality was once considered a psychological diagnosis. Drapetomania was a diagnosis of individuals who were in bondage or slaves and who didn't want to be slaves, and they actually diagnosed them with a mental condition. Well, I can guarantee you I've never been a slave, but I would have that condition because I don't want to be a person that is in bondage. There are many different diagnoses that have fallen out of favor over the years. And again, we just need to be flexible and recognize that this is a maturating field and that the world of diagnosis is going to markedly change in the future. For the better, we hope. Lastly, we know that musculoskeletal pain is complicated, that even individuals who have the same condition will have tremendous interpatient variability in their response to interventions. And that's because they have different pain phenotypes. In other words, the way they manage their own condition, their body manages it, the way they modulate their pain is different. If you've seen one patient respond well to an intervention, you've seen one patient that will respond well to that intervention. We need to recognize that, and we need to be flexible on how we manage those conditions. And we need to know that there are many factors that influence pain phenotyping, including sleep and fatigue, a person's endogenous pain modulatory processes, their exogenous pain modulatory processes, their sensory profiling, their pain variability or pain quality, and psychosocial factors. And lastly, and I think this one's the most important one, if you've ever seen me speak live or have taken any of my online coursework, I will tell you, don't fall in love with the clinical tests, because clinical tests can only do what they're allowed to do. And clinical tests will only function well in identification of red flags or in very specific conditions that have a strong biomedical attachment. You can tie that condition to a tissue. If you cannot tie a condition to a tissue, non-specific somatization disorders, or chronic pain syndrome, then the test is not going to function well. So don't fall in love with tests such as the active compression test, which our physician colleagues have fallen in love with and use almost in all clinical environments, even though the test has no clinical value. So don't fall in love with clinical tests. Be adaptive with respect to that, and do your best to be functional and nimble. I really appreciate you watching this. I had a wonderful time presenting it to you, and I wish you all the best in these very interesting times.